Today we're going to talk about Lyme disease and the co-infection testing. And of course, I'm Bob Giguere. I'm with IGeneX Laboratories. So over the next hour or so, we're going to talk about the diseases and their spreading across the United States. The Lyme disease in particular, looking at the current testing technologies that are available in the tests. Then we're going to look at our new ImmunoBlot by IGeneX, and then we're going to look also at the co-infections and where they stand in different locations in the United States and why they're becoming more and more important to pay attention to. So the ticks are the big problem, and as any of you watching this probably already know, they are growing in real issues throughout the country. And here are, from IGeneX's standpoint, the testing we've had in the last year that we've seen is positive for all, not only Lyme disease, but also tick-borne relapsing fever and the co-infections. And as you can tell, where we see Lyme disease, we see a background now of these co-infections becoming more and more a complication for an already complex disease. So Lyme disease is the most prevalent tick-borne disease in the United States, according to the CDC. And I'd have to say that pretty much is played out everywhere else. They'll tell you it is. And that it is a clinical diagnosis, at least they try to make it one. And in the early stages, you'll see often a rash in 40 or 50% of the cases. Usually the patient also gets a neck pain, a little stiffness, some fatigue in the afternoon, and they may actually have a slight afternoon temperature and a subnormal in the morning. As it disseminates out, as Borrelia moves around in the body, we start to see the joint pain, which is migratory. That migratory pain is a clear symptom of being at Lyme. Arthritis itself does not move, so the differential diagnosis there is kind of a little easier. And of course, in later diseases, we have the neurological involvement of many children who like to roll around in the dirt. Borrelia does have an affinity to the neck muscles and the facial muscles, and so we do see the palsies develop in children. And as you all are aware, there's also a far more deadly complication, often caused by cardiac involvement of the bug, because we are seeing more and more cardiac issues with it. So what happens and how does it come into the body, and why is this bug so complex to diagnose? Well, it starts out with this wonderful little tick, be it one of the 6 or 7 species that we now know, according to the CDC, can transmit this infection in others. What happens is the tick, as you can see up there on the left, attaches to the host, in this case a human, and what happens is the first thing it does is suck out blood. That sucking out of the blood changes the the temperature within the bug, and actually causes an outer surface protein change from A to C, and the multiplication of it as it develops over 100,000 copies in about 24 to 36 hours, and sends that copies of Borrelia burgdorferi from the initial 500 of them into the body, into a little bubble of blood under the skin. Now, in the initial infection over there on the right, you'll see that the T cells actually are the first reaction you'll get to this, because the dendritic cells, which live right underneath your skin, see this foreign object. And what happens is they engulf it. They send the information immediately to the T cells, which start to become mature, and like the NK cells, will attack the bug right then at the site of the bud. But the B cells also get a hold of this, and it's transferred out to the lymph nodes, where an antibody response is developed over weeks and months to remember this bug and to become far more focused on it. The T cell activation, which happens early on, is also repeated late on in the disease when the macrophages effectively do what the dendritic cells did. They see this foreign object that's come out of tissue into the blood again, and they say, hey, this isn't supposed to be here. They engulf that microbe or that Borrelia, dissect it, effectively engulfing it and sending it off through the helper T cells to have both a B and another T cell response. That's why we can see different reactions throughout the stages of the disease, and why we see a reactivation being a real problem. So what we need to understand here is exactly how the body responds, and how the requirement is now that you can't just use one simple technology test, because this bug is way too big and definitely way too smart. So early in the disease, as I mentioned, the bug bites you. You get an early T cell response, as you can tell in the early stages. Usually within 2 days to 3 days, you will get a nice T cell response that is measurable by some tests, one of which IGeneX, of course, has. Then later on, as the T cells develop, and after 3 to 4 weeks, you'll notice here in the middle ranges, you start to see an IgM response. There is testing there by antibodies. And when the IgM starts to ramp up, there is an opposite effect on the body where the T cells are actually down-regulated so that you don't have both trying to fight for the same thing and growing. And as they drop off, the same thing again happens with the IgM. After 5-10 weeks, we actually will see an IgM drop off, and the IgG should give you a long-term perfection against the bug, as it is a far more specific antibody than the IgMs, looking only for the bug that it saw in the early phases or in through the that was transmitted to it. And again, in the late stage, the problem is the bug is reacting to all of these different responses by your immune system. And so the ability of one specific test to always be effective in later stages is definitely called into question now. So let's talk about the different testing methodologies and why lab medicine has failed in this bug so long and so hard. We're going to talk about, first of all, indirect tests. Those are tests that look for antibody response. So when the bug is in there, you try to develop antibodies against it. And we use techniques like ELISA, Western Blot, ImmunoBlots, or an immunofluorescence. We also use cellular responses, which are, again, looking for serological response. They're looking for the immune response of the host. And those are the T cell activation tests. We're going to talk about IgXSpot, but that is actually an ELISpot technique. And then we're going to talk about the direct tests, looking for the bug itself, DNA, RNA, even culture of it. And we're going to look at why and where all of these techniques work and why and where they don't. So all commercial laboratories, for the most part, will be offering you an ELISA or a Western blot. And the kits used in the early stages are more than appropriate for the first month, 6 weeks, 8 weeks of the disease. It's later on that the problem becomes up, and there are different places, again, where the T cell works, where the PCR works, and where the ELISA or the Western blot, including the reflex, are appropriate. So let's look at the problems that start, and it starts with the sensu lato strains. Borrelia burgdorferi, back when Dr. Burgdorfer found it and named it after him in the early 80s, we found a lot going on since then. Of the 52 strains of Borrelia in the that we know of, these are all what are known as the sensu lato. Borrelia burgdorferi is the sensu stricto. That is the one strain that Will Burgdorfer found. But there are a lot of strains that are very similar, and they do cause Lyme disease. And they are called the sensu lato strains, and you can see them all here on the left. IGeneX Laboratories, unlike most laboratories, does test for most of these, and our testing does pick most of them up. And so if you've been in Europe, we will pick up the Afzeli Guarani. If you've been in the Midwest, yes, we pick up the Mayoni strain. And of course, if you're in the Western Coast, we picked up the Californias and a number of these other strains. So, because most people do travel, you have to be cautious. You should be testing for all or most of the strains if you can. One of the things IGeneX did early on was realize after the meeting in Dearborn, Michigan, where the CDC in 1994 told us what we should be looking for and what strains we should be using. The people here at IGeneX under Dr. Harris's tutelage actually developed a Western blot that not only looks at the B31 strain, that is the strain that Willie Burgdorfer sequenced and put out there, but also we added a second one from the wonderful work being done up at Stony Brook by Dr. Golightly and his group, and that is the 297 strain. Those two strains add a little bit of make the test significantly better, and we're going to talk about that why. Because we also have to worry when you're using Western blots about cross-reactivities to other viruses, and so we need a test that is specific just to the Borrelia burgdorferi species. So let's go back to what the CDC told us all in 1994 in Dearborn, Michigan. It was a meeting put on by the CDC and Astafelt, the Association and State Territorial Public Health Lab Directors. There were about 500 scientists there. And while we were there, they told us we were going to do a two-tier approach, where you would do a screen test, an ELISA, followed by a Western blot when you got a positive or equivocal. If you got a negative in the ELISA, you did not have to go any further. That may be a little problematic. And the second tier test, of course, should be a good Western blot. The reason I called that sensitivity a little problem with the ELISA is we have found over the years that the ELISA assays out there just don't stand up. They and I'll show you the technique and why it happens, they are going to be right 70% of the time at best. There are a number of studies that show ELISA's picking up this disease in less than 50% of the cases. So we've got a problem here, and we've got a test that isn't sensitive enough. Sensitivity is what you really want in early disease, a screen test. You want that screen test to give you all the positives, if it could possibly be. Even if it is only close and looks like it, you really want to get a false positive, because in a two-tier approach, you have to confirm that positivity. You really don't want a false negative. This is very similar to what you don't want in an HIV type test. You want to have false positives so you confirm that that's what it is. You definitely don't want to have a false negative in those or any infectious disease. So what do we do with an ELISA, and why has it failed it so much? Well, it's a wonderful technique that's worked over the years. And what it does is, as you can see these up in the upper yellow, those are the antigens. Those are the specific surface antigens that we see on this diagram of a bug. Down at the bottom are the antibodies that are specific to that specific antigen from that bug. And they will attach the antibodies only to the antigens that they are built to go after. And that is the wonderful way ELISA works, and also the problem that often develops because Borrelia burgdorferi doesn't pay attention. An ELISA assay is a 96 well plate, and into that plate along its walls are antigens of interest that are put on there by the manufacturer. And what that does is those antigens are very specific in most cases to Lyme. And then what we do to those, into each of those wells, is you pipette in the human serum. And the human serum, and in this diagram you'll see this cute little red thing, will have antibodies in it. If antibodies that are specific to Lyme disease see those antigens on the wall, they will attach. They will form what's known as a nice immune complex. And then we'll do a wash cycle and use a second antibody with a fluorescent tag on it to look for that immune complex. It'll bind and glow. The one on the left here has antibodies that were specific to the disease looking for. The one on the right did not. The antigens with antibodies didn't have anything to attach to, so they just floated around. You wash them away and you got a negative lab test. Now, the problem of this whole technique is there are a lot of other diseases that produce a lot of other antibodies of similar size to the antibodies for Lyme. And they will all compete in that cute little well to try to find a place to attach on those limited number of antigens. You will get incomplete binding, non-specific binding, and even if you've got some antibodies floating around, they may not find a way to get a nice strong immune complex, because then there's a wash cycle and it gets moved off. Now, what's to add confusion is that we have known over the years, since the early days of Lyme, that a number of different bands or outer surface proteins are on this bug. These are the proteins that these antibodies look for and attach to. And so you'll see on the left of this slide bands which are KDA, that's the molecular weight of the size of the band. And these are the bands that are specific, we hoped, back in the early 90s and all these phases, to Lyme disease. But what we found across years is that a lot of these not only cross-react with it, the only reason they're there is probably because it was a different disease. So specificity of Borrelia burgdorferi bands has always been a problem, and even in a Western blot, it also adds to the confusion. Now, a Western blot is nothing more than a transferred piece of nitrogenous cell. It's a piece of paper from a gel. In the gel on the left there, what we have done is you use the antigens that are specific. They're spread throughout the blot there, that gel. And when you pipette in the human serum at the top in lanes, usually lanes 1 through, there's usually an 8 lane here. Usually you put them in, do 8 or 9 patients, and you do controls at 1 and 10. And what happens is you will have an immune complex form between the human serum that you plugged it in this little trough, and they would form a nice immune complex with antigens that match them that you put into the blot. When they form that immune complex, you transfer it over to that piece of paper on the right so that it doesn't move, and now you can read it through a scope or through other area means, and you will see the specific bands related to, hopefully, the disease you're looking for among that, all the bands that are there. So what happened back in 1994 is the CDC set some criteria as to which bands are appropriate, and they've picked the ones, as you can see on the right. You needed 2 of 3 bands during the IgM phase of the disease, and then you needed 5 of 10 for the IgG, because really in 1994 we didn't know what the long-term implications were going to be, so better be safe than sorry, pick 5 out of 10. Our bands at IGeneX Laboratories still included 31 and 34 for the reasons of the vaccine. Without having them in there, as the CDC wanted them to do, they wanted them removed by a kits. So any laboratory that uses a kit, it has to be FDA approved in the United States. It is not allowed to have 31 or 34 in it, because if the patient got one of the vaccines, the outer surface protein A1 was the Lyme vaccine that was on the market from about 1998 by SmithKline. The 34 KDA vaccine, which never got to the market but was studied heavily in the United States, was being developed by bioMérieux, another large farm. So labs like IGeneX, the people at the University of Connecticut, the people down at Yale, and the people at Stony Brook, we were all told at the meeting in Dearborn in 1994 we could continue to include 31 and 34, basically because we knew what we were looking at and could tell the physicians ordering it at the institutions that, hey, 31 and 34, if your patient had the vaccine, you got to discount them. But the CDC, in their efforts to standardize this, pulled them both out so there wouldn't be any confusion as to what were they considered a positive or a negative. But there's another wrinkle that happens with Borrelia burgdorferi, and that is called quorum sensing, a bug's ability to change its outer surface proteins. Now, many bacteria can do this. It was proven in Lyme disease by Brian Stevenson et al. In Infection back in 2002, and published on by a number of other scientists, that Borrelia burgdorferi and the other strains of Borrelia, having over 126 genes on them, are able to change the outer surface proteins to combat or come up against the immune system and response of the host. So there is an ongoing battle where the proteins will change during the life cycles of the bug to help defend itself or hide it from the immune response of the host. And so we're going to talk about ImmunoBlots and why they work in a few minutes, and why we get past some of the problems of Western blots. And why is that so? Well, as I told you, a Western blot uses a whole cell, and they're put in, and on the right there you can see all of the different bands. But if you look to the left, you're going to see what we now do is called our ImmunoBlot from IGeneX. Now, the ImmunoBlot from other laboratories doesn't quite do this, but IGeneX uses recombinant proteins for all of the sensu lato strains of Lyme. What that means is, say in band 23, which is the outer surface protein C, we see a minor differences in each of the different strains that are now or have been known as the outer surface protein C. And some of those strains are picked up by some tests. All of those strains are picked up by the IGeneX ImmunoBlot. And how good is it? Well, let's compare our ImmunoBlot with our criteria against our ImmunoBlot using the CDC criteria, and you can tell the sensitivity of this ImmunoBlot is exceptionally high, and the specificity exceptionally good. Specificity shortcoming is very minor. It is actually overcome more and more by the addition of the other proteins we're now looking at. Compared to a Western blot, you can see that using on 1,000 patients that we've looked at for overall performance, you see a significant increase in finding patients with low positivity for a Western blot. Even our Western blot, we're able to pick up a significantly more presence of Borrelia or one of the sensu lato strains in the patient population of 1,000. So one thing I've been avoiding here and haven't talked to you much about is, where do you add a PCR? Should you be considering PCR with ImmunoBlots? Well, when we look at our data on almost 300 samples, most of them supplied to us by the CDC, we notice something here, and that is you may pick it up with the ImmunoBlot, but when you add a multiplex PCR, such as ours, your percentages go up. That 15, maybe 20% of people who can't produce or don't produce antibodies, the immune system is suppressed, and now the Borrelia is out in the blood again, moving around because of its ability to sense when the immune system is suppressed. You need to have something of a direct test that looks for it in the blood. So let's talk about PCR, why it's good and why maybe it's not the end all. Okay, DNA amplification is called PCR, which is polymerase chain reaction. What it is to take this wonderful thing called a double helix, and what it does is we denurture or take apart those two strands coming down so that you can see them separately, and then using temperature, and we are able to through this procedure denurture, pull them apart, and now you've got single strands of DNA that you will use what are known as the cutting primer sets along with cutting enzymes. Now the cutting enzyme is like a scissor, and it will cut the DNA at specific sites and only at that specific sites. So we're looking for the DNA of a bug, which is super specific. We're cutting it up into pieces that are absolutely specific only to that bug so that they don't cross-react with possibly other species or even that aren't causing, in this case, Lyme disease. And you want to make sure you are able to multiply those out. So you use very specific, what we call primer sets. And what happens in PCR is once you have the two strands separated, you use an exact mirror image of a piece of DNA, probably about 20 base pairs long, that goes to both ends of that little piece that you've cut, and you put it through the thermocycler, which literally makes a second copy of, actually an exact mirror image of what you've got there. Now they call these cycles, so you do one cycle and the two become 4, the second cycle the 4 become 8, third cycle 8 becomes 16, and you go on and on. For HIV and PCR technology, most labs use 25 cycles. For Lyme disease, IGeneX actually uses 50 cycles, so that we get a significant increase in the number of pieces of DNA that we can then southern blot, which is similar to, which actually tells you that, make sure that it is Borrelia burgdorferi or sensu-lato strain that includes those specific DNA pieces that you have sequenced up and multiplied up. So we use not only genomic PCR, which is what everyone uses, but we also do a thing called plasmid PCR. Plasmids are little pieces of DNA that stick off of the Borrelia. They are identical in part to parts of the DNA of the total bug, and we are able to take pieces of those because the bug actually will break off them while it sits in tissue and send those little pieces of plasmids called, or blebs, as they're often called, and they will be testing the body's immune response in the blood to see whether the Borrelia wants to come out of the tissue. So by looking for plasmids, which are much more prevalent in the blood, we are able to give you a more positivity rate of actual active presence of the bug, whereas other tests can't. So in well-characterized controls, our proficiencies, we have scored over 98% overall in specificity. This is a very, very specific test. The problem is, if there is no Borrelia in the blood, we are going to miss it because there is nothing to amplify up through PCR. Low sensitivity is the hallmark issue of Borrelia burgdorferi testing for Lyme disease. And I know there are companies who think you can find more of it in urine. Well, our handle on using this since 1991 is yes, it's a little better, but nowhere near enough. The presence of Borrelia is not there in an active immune system that is actually fighting it. It is hiding in the tissue. You're not going to get it into the urine. So our assay sensitivity, as you can see there, in the urine you can find more of it, but still less than 30% of the time in any PCR test are you going to find Borrelia using PCR as the standalone technology. So let's go back again to the Lyme diagnostic, the different times of disease. And in the chronic infection is where we are most worrisome, where we don't know if it's T-cell response, producing to a new infection or an old. Early on, we know that in the early infection, T cell response is very good. So the IgXSpot test, which is a T cell response, ELISpot, actually looks for that T cell response, which is actually an interferon gamma release. Now, when I go back here and I look at this first slide, the top of it, you can see that the dendritic cells just below the line of the skin have picked up this bug. That's what's causing a lot of that red. And it is now digested the bug and sending out the data into not only to form a B cell response back through the lymph nodes to produce antibodies, but it also, of course, triggers a T cell response right there at the site immediately. So in early Lyme, you will find that at day 3 for the first few weeks, as I showed you in the other slides, you should see a T cell response. Late in the disease, when the bug has been hiding in tissue, a year later in the chronic infection stage, the dendritic cells don't have an effect because the macrophages are what are in the blood when this Borrelia decides to come back out of the tissue and present itself into the blood. Your macrophages will pick it up. They'll see this foreign object. They'll digest it. And again, they're going to do the same thing that the early stages did. They're going to send it out to T cells to produce a B cell response and also an immediate T cell response. So, does the test work? Yes, it works very well in very early Lyme. Does it work well in late Lyme? Not so much. And the reason is, if the immune system is producing antibodies in late disease to the Borrelia, any of the Sensu-Lato strains, this is going to downregulate the T cell response. T cells only live active and live for 5 weeks. If you have antibodies there already downregulating the body to stop producing so many T cells, and you add on that the T cell response is limited by the life cycle of the T cell to look for specifically through interferon gamma release through a few of the other proteins that causes the interferon gamma release, you're having a problem. So using this test to monitor treatment is a very dangerous situation. The science doesn't show it works. The science of the human body and immunology, so you should not be using it. So we suggest in late disease, if the patient is showing symptoms and you think their immune system is very suppressed, you should add this on. We will never have this test as a standalone. We suggest you not use it as a standalone, only because making the diagnosis of a negative here does not dictate there isn't Lyme there. You've got to be, as I said, exceptionally cautious using it in late disease. So again, going back to the early slide that I have, there are a number of technologies you need to consider through the stages of the disease. In the very early stage, as I've shown you, scientifically, both the PCR test and the IgXSpot could come up and should come up early positive. Later in the disease, as the T cell response is downregulated and the IgM response goes up, you can continue to use the IgXSpot as it slowly goes away, but it is better to consider immediately to go to the ImmunoBlots or our Western Blot. You can include an ELISA or IFA or maybe a PCR, but again, you're getting into an area where I strongly suggest the use of the ImmunoBlots. Their sensitivity and specificity is far beyond anything else we have in the market or ever seen in this environment before. Disseminating disease up to a year, stay with the ImmunoBlots and maybe the Western Blots as the proof. And if you need a secondary or a second to get two-tier approach, add either the ELISA, which I'm not overexcited about, but our IFA is a significantly better test, so I'd suggest you use that one along with an ImmunoBlot. And in later disease, you really do need to start with both the ImmunoBlots and probably using the IgXSpot to see if there is a T cell response. But the ImmunoBlot in late disease should be present. Adding PCR will pick up those patients whose immune systems are totally suppressed, where you won't get an IgXSpot to that result or an ImmunoBlot presence. So adding PCR in late disease to ImmunoBlots and IgXSpot makes scientific sense. And that's what we strongly suggest you use. So now we're going to step forward into what we're seeing now in the United States and what's getting worse every day, and that is the major co-infection called tick-borne relapsing fever. Now, how bad is it? And if you had laid this slide over the line of Lyme, you'll see that the relapsing fever strains of Borrelia, which are known to be the Miyamotoi, Hermsii, and a few others, the Takati and Pakari in the United States, that they are showing up across the United States in Lyme endemic areas, and they're being missed. Now, there are 17 different strains of tick-borne relapsing fever, and we at IGeneX are picking up the ones that are here in the United States that have been found so far. Stay tuned, that may change. So, what about tick-borne relapsing fever? One of the major strains, the one most studied now, is B. Miyamotoi. It was first published on by Dr. Krause's group out of the New England Journal of Medicine, and he's seeing it. And there's the statement from Brian Fallon a few years ago that the problem is going to be missed because this disease looks like, feels like, tastes like Lyme disease, but when you test for it with a Lyme test, it comes back negative. How bad is that? Well, you can see that when we looked at 1,000 patients where we had done either just our Western blot or our ImmunoBlot, when we added the ImmunoBlot for tick-borne relapsing fever, we found a significantly high number of patients that would have been missed if we hadn't done relapsing fever. We're going to talk about other co-infections now, because as your immune system does get suppressed, as I mentioned, the interleukin suppression and the short-circuiting of the immune response happens, co-infections such as Babesia start to rear their ugly head. How bad? Look at this slide. Yes, this is our presentation of Babesia that we've seen in the United States, and it fits pretty well right over the Babesia slide that you can see on the CDC website. Babesia is becoming a growing problem. It is a parasite, opportunistic, that often when it appears, and it doesn't always appear, but when it does appear with Lyme disease, it is problematic in that it enhances it. And one of the newest strains, the McCarty strain, of course, was found here. It was found in the Northeast first. The Duncani strain used to be known as WA1, first found up in Washington State. But the Duncani strain has spread across the United States, so both strains are being found not only in ticks but in people throughout the United States now. And the new B. Missouri strain out of the Midwest is called Mo1, has been reported not only in Missouri but on the West Coast, and I'm sure it's only a matter of time before we'll see it on the East Coast. So this parasite has a lot of problems with it. It is like malaria, and it can be fatal, especially in people who are immunocompromised or the elderly. And symptoms can be severe when they're alone, but when they're concluded with Lyme, the symptoms are even more pronounced. So the testing that are available for Babesia includes PCR, Babesia testing, or direct smear, and that is the direct test. And up until now, most of the people will continue to use Babesia macroti or Babesia duncani slides done by the technique of immunofluorescence, and then we've of course now got a Babesia macroti ELISA assay. The problem is that the slides for both of these in the indirect test looking for the immune response don't necessarily pick up both strains. They only pick up either macroti or duncani, and you need to order both if you are going to do a screen test, which are the indirects. So this is the indirect test technology that's used. It's called immunofluorescence. And on the slide, you can see here, you put the pathogen that's of interest. You then take the human serum on it, and you put that patient serum on it. And if there are antibodies in the serum that match up to the proteins on the surface, they will bind. They'll form an immune complex. You then will do a wash cycle. You'll add a fluorescent tag. That fluorescent tag will glow and form either Maltese crosses or most other things, but mostly it's called a Maltese cross. What they do, you look through, the pathologist will see through a scope to validate that the immune response is present in the blood. The problem is that the Duncani and macroti, again, don't cross with this IFA, and you can see here from all of these samples that there is a cross-reactivity, but not enough that everybody with Duncani, if you only test for it, will be picked up by macroti and vice versa. You need to do both tests. So one of the techniques that's now used across the United States that Dr. Richard Horowitz helped us with, and the technique has been used for years for other things, it is called fluorescent in situ hybridization. I got a much more in-depth understanding of this and presentation for you in a later slide presentation that we'll do on the specific tests. But understand that we're looking in fluorescent in situ hybridization for the RNA. RNA is active live bug. So if it's alive and running around in your body, a fluorescent in situ hybridization test will use specific probes to glow and find the RNA, and you should be able to, as in our test, and here you can see the New York State Department of Public Health proficiency testing on us, we were able to pick up about 98% of the Babesia, and the good news is these probes that we use not only pick up Duncani, but they also pick up Macroti, and we're now finding a few other of the strains, including the divergence. And in animals, we're actually seeing a couple other phases that we expect to also be picking up in humans. And of course, this is the blood smear the pathologist sees. These are called Maltese crosses. That is Babesia being lit up, as we call it, by fish. And Duncani smear looks pretty nice too. Painted that red. So what happens if you do just one technology? A problem here is the same as with Lyme. Babesia is a smart bug. It does know how to hide. And so the fish or IFA technology may miss a number of the cases. So the problem is here, and we suggest that you do both our fish and order the IFAs for both Duncani and Babesia, Macroti, in order to have an effective tool. And the reason I want this done, we'd like this done more, is that this is a very, very problematic parasite. It is a deadly one. We need you to make sure that the patients are healthy and that this isn't a problem and it needs to be taken care of. So that's why we suggest 37% of the time we would have missed, as Richard Horowitz says, if he had just used either PCR or not used fish and just used the screen tests. So the conclusions are, again, and I can't say this enough, is to use a screen that includes literally a panel of all three of these techniques. The next co-infection I want to talk about is Bartonella. Bartonellosis is a problem. And here's another slide with all of the problems we've gotten that have been positive. All of these slides that show that I put up of maps of the U.S. are IGeneX slides of positive test results in the last year that we've gotten from across the United States by the many thousands of physicians who use us. So the Bartonella strains that we know of in the United States, there are at least 15, but in humans there have only been found the ones on the right there, the Henseley and Quintana. Those are the tests that have been used for years. People have looked for either Henseley or Quintana across the country, but the Elizabethan and a few others, including Vinsoni, have been popping up. Vinsoni in the southeast is becoming a real problem. It is often referred to as cat scratch fever or trench fever, but understand that we're not sure of the way this gets in. It doesn't mean you had a cat, but we don't know the exact method of transport of this into the human. So Bartonella is a Proteobacterium, and its transmission, as the little question mark says, we're not absolutely sure what the vector is. But we know it's there, and we know it's causing people to have a significant number of neurological issues, including endocarditis and others. And it's been an underlying problem that you're going to find in a growing population, as you saw from our slide of the map of the United States map, in patients here. Now, the testing methodologies for indirect, as I mentioned, have always been Henseley and Quintana, but they haven't looked for the others. You could use a fish Bartonella that we have available, not available in New York, and that also looks for the RNA of Bartonella, so it is active live bug, and it can pick up all of them. Or what we suggest now as a screen is the Bartonella Western Blot, because our Western Blot does pick up all of the different strains, and in late stage disease, many of those strains, or whichever one it is going to be picked up as either an IgG or an IgM. And as you can tell from this, our Bartonella Henseley by itself, you can tell the positivity rate, But here you can see when we use the Western blot, instead, you actually pick up a significant increase in the number of Bartonella that would have been missed by using an IFA, because as you can tell, these are the 4 strains we absolutely know we pick up. So the IgSpot test is also a T-cell response test, but it has the same problematic situation because of the science of the immune response. If the body is producing antibodies, the sensitivity will drop. Specificity of the test is exceptionally high because, like our IgXSpot for Lyme, we use recombinant proteins, which are absolutely specific to the release of either the Bartonella strains or the Lyme, the interferon gamma in the IgXSpot Lyme test. So the specificity is exceptionally high. Sensitivity is low only because we are not sure that the human body is not producing an immune response, antibodies therefore, that are suppressing or downregulating the T cell. So Bartonella conclusions, fairly simple. I strongly suggest you start with the Western blots, but across the United States, the Western blot is the best test that we have available, especially for screening in the patients with Bartonella. The other co-infection that often rears its ugly head is Ehrlichia and anaplasmosis. There are direct tests for it and the indirect. Most doctors will use the indirect test for the Anaplasma or Ehrlichia for IgG and IgM, and those are immunofluorescence tests that I've already talked to you about how the technique has worked. So the panels for Borrelia, we do start with a panel that now includes both Lyme and relapsing fever. As I mentioned, the relapsing fever growth has been pretty outstanding, pretty aggressive. And the co-infection panel is the follow-up if you think there's a number of other co-infections. And if you want to look at everything all at once, the tick-borne disease panel, you can look at our website and our test requisition form to look at the different panels, and feel free to call IGeneX laboratories and talk to our client services or your local representative about what specific panels fit the clinical setting that you're looking at. Because our panel is here, it is certainly not cheap. Remember, we are a Medicare provider, but if you ordered these tests separately, it would be over $2,000, and getting all of these tests definitely clears you in finding out whether we are looking at Lyme or tick-borne relapsing fever, regardless of the stage of the disease. Our co-infection panel, like our screen panels, this panel does pick up Babesia, Bart, Anaplasma, Ehrlichia. It uses a host of technologies, all of those that we think are definitely appropriate to pick up Bartonella. And as Bartonella becomes more and more of a problem, where you think this is the biggest issue, and as patients who's been handling the disease for a long period of time, this may be the best place to start before you start the treatment protocols. And of course, when it comes to you're really confused, you don't know where you're going, if you decide you want to use panel that it looks for not only Lyme and relapsing fever, but all of the major co-infections, this is what we strongly suggest as the panel of choice. So IGeneX Laboratories was founded in 1991 by Dr. Nick Harris. It is now run by our leader, Dr. Jyotsna Shah. We are clear and CMS certified. Major thing that you need to think about when you are practicing medicine or doing testing, you need a clear licensed laboratory, because you want to make sure the test you get meets all the quality controls that are put upon people, which are appropriate by the U.S. government through CLIA. That's how you get a licensed lab in the United States. That's what you should be using. A lab that doesn't have a CLIA license is pretty, you're putting yourself and patients, of course, in danger. So what I can contend with is thank you for listening to this. The most dangerous test result is a false negative. We at IGeneX are doing our best to not give you any of those. We develop tests every day and are continuing to work to try to stay ahead of this disease as it continues to confound the medical community, and it grows, and so will we. Thank you.